Let me just minimize all this. Okay. So wrist, today we are going to, yeah. So we are going to talk on wrist MR. We are going to have a systematic approach to the MR imaging of wrist. Wrist has a complex anatomy, and that's what makes it challenging with multiple small ligaments and the carpal bones. So we are going to see each one of it. So let's simplify it. We are first going to see that we get good images. So we'll discuss the MR protocol, know your anatomy. We'll look at the ligaments, TFCC, tendons, each one of the components separately, and the pathologies associated with it. TFCC, Palmer classification, and why is it important? Why, how it guides treatment decisions, and have a look at common pathologies. This is the first part of our lecture today. After that, if you're up for it, if you're not tired, we'll take questions in between, and later on we'll do the carpal instability part. All right. So for wrist MR, we need a dedicated wrist coil. The position has to be in wrist neutral position at the side or an overhead prone position like the Superman position. One very important thing that we require in MSK is using tablet markers generously. Try to put tablet markers whenever the patient complains of a particular pinpoint pain, because especially so in small joints like wrist, because when we do come across incidental other findings also, and the presence of a tablet marker helps us to narrow down and pinpoint towards the pathology which is causing the complaints. It's important to obtain small FOV images so as to get better resolution. Here you can see a large FOV image compared to a small FOV image on a same scanner. Next, higher strength magnet, if available, obviously is better because the signal to noise ratio is better. So a 3T would definitely give better images as compared to a 1.5T. Our usual protocol involves a fat suppressed PD in all three planes. Besides that, a non-fat suppressed T1 is obtained at least in one plane. If required, we obtain another one in the coronal plane, especially when we are looking for the bone pathologies. And a gradient image is obtained, additional gradient image, especially so when we are looking for cartilage abnormalities. Let's start with the ligaments. So ligaments, there are extrinsic ligaments of the wrist and the intrinsic ligaments of the wrist. What are extrinsic ligaments? They originate from the forearm and insert into the carpal bones, whereas the intrinsic ligaments are the ones which originate and insert onto the carpal bones. So we are right now, I'm not going to talk about the extrinsic ligaments because there are a set of complex extrinsic ligaments both on the volar as well as the dorsal aspect. Right now, we will talk about the intrinsic ones, scapholunate ligament and the lunotriquetral ligament, which are the most important ones and associated with various pathologies. So a scapholunate ligament, it's a U-shaped ligament which joins the scaphoid and the lunate bone. It has a triangular appearance if you see on the coronal images, and that has to be a black low signal intensity triangle. On the axial images also, you can identify this as a triangular component on the volar as well as the dorsal aspect and a thin interosseous component. Now of this, the dorsal component is most important for stability, because whenever a scapholunate ligament injury occurs, it breaks from the palmar to the dorsal aspect, and it is the last brink that occurs, and the dorsal component breaks, and then eventually the scapholunate dissociation occurs when the extrinsic ligaments are also injured. So this is an example of a scapholunate ligament tear. You see tears are seen as a fluid signal within the black ligament. Here it is associated with an interosseous cyst formation or a ganglion cyst. Scapholunate ligament, most commonly, they are associated with a dorsal ganglion cyst. That is typically which occurs in continuity with the dorsal component of the scapholunate ligament. It lies in the dorsal aspect of the wrist and deep to the extensor tendons. There can be occult ganglion, but here you can see that the tablet marker is placed at the site of the complaints, and this was the cause for what the MR was done. Also, these dorsal ganglion cysts may have interosseous extensions. So the bone involvement with the ganglia can also occur when they enlarge. Now, when the scapholunate ligament is completely torn and associated with the extrinsic ligament injury, there occurs scapholunate diastasis. This means that the scapholunate interval, it increases. Normal scapholunate angle, usually it is about 2 to 3 millimeters. When it is increased greater than that, that is scapholunate dissociation or scapholunate diastasis. And this is known as the Terry Thomas sign. Terry Thomas, he was a British comedian in the 50s, and he had a gap in his front incisors, and that's from where the sign has come. Okay, so, and this was first described on a radiograph. Now there are multiple celebrities who have this so-called Terry Thomas appearance on the front teeth. Now, once the scapholunate ligament injury occurs, there is concomitant failure of the scaphoid stabilizers, and eventually permanent carpal malalignment occurs, meaning there is the lunate axis, it tends to tilt. This is the lunate axis, it tends to tilt dorsally. The scaphoid, it tends to tilt volarly, and this results in an increased scapholunate angle. Normal scapholunate angle is between 30 to 60 degrees. When it gets increased to greater than 60 degrees, and the capitolunate angle greater than 30 degrees, this is known as DISI, or dorsal intercalated segmental instability. When it occurs due to a ligamentous injury, it is known as a ligamentous DISI. The other part, what all other pathologies can cause DISI, we'll discuss in the carpal instability part. Right? So, to remember, DISI is dorsal tilt of the lunate axis, wherein there is scapholunate angle is increased greater than 60 degrees, and capital lunate angle also increases greater than 30 degrees. And there is disruption of the scapholunate ligament. Now, once the ligament tears, scapholunate dissociation occurs, there is a pattern of malalignment occurs because of and gradually the osteoarthritic changes set in. So that is known as the scapholunate ligament tear with scapholunate advanced collapse, that is slack wrist. There are 4 grades, depending, that is according to Watson staging. It starts with usually the cartilage abnormality. It begins at the level of the radial styloid and the scaphoid. So you have to look at this cartilage. When you look at the scapholunate ligament tear and dissociation, you start looking at the cartilage as well, whether what all joints are involved. Later on, the whole of the radioscaphoid articulation is involved. Then the osteoarthritic changes or the cartilage loss involves the capitolunate joint. Later, it is the other radiocarpal joints, the scaphotrapezio-trapezoidal joints that are involved. And lastly, it is the dorsal radio-ulnar joint that is involved. So when osteoarthritic changes occur between the radiocarpal and intercarpal joints as a result of scapholunate ligament tear and dissociation, that is known as the slack wrist. Now there is another entity that is known as SNAC wrist, that is scaphoid non-union advanced collapse. Here the cause is not the ligamentous injury, but a scaphoid fracture. So a non-united scaphoid fracture, and later on, because of the change in the dorsal tilt of the lunate and the scaphoid, which goes into a volar tilt, there is eventually so that is a bony DC that is associated. Sorry, I got a little confused. So scaphoid fracture, when there is distal scaphoid fracture fragment flexion, it tends to flex or get displaced in a it gets flexed, it tends to tilt, the fractured fragment, it tends to tilt. And because of this, there is abnormal radioscaphoid articulation. Eventually, the osteoarthritic changes set in, that is known as the SNAC wrist. So when there is a bony cause or a scaphoid fracture non-union resulting into degenerative changes at the radioscaphoid articulation, that is known as the SNAC wrist. Coming to the lunotriquetral ligament, So lunotriquetral ligament is a triangular ligament that is seen between the lunate and the triquetral bone. It has a triangular configuration at the proximal aspect, whereas at the volar aspect, it has just a parallel thin strip-like appearance. This, when you see a fluid signal at the level of the lunotriquetral ligament, it is suggestive of a tear. Here, unlike the scapholunate ligament, where the dorsal component is most important, lunotriquetral ligament, it is the volar component, which is the volar component, which is which is most important. Now, when there is a presence of a step off between the lunate and the triquetrum bone, or there is associated TFCC injuries, or there are changes of ulnocarpal abutment, that we'll see what is ulnocarpal abutment, then you should specifically look for lunotriquetral ligament and the status of it, whether it is torn or not. So when a lunotriquetral complete tear occurs, there is volar tilt of the lunate axis, and the scaphoid remains attached to the lunate because there is an intact scapholunate ligament. And that results in an increased capitolunate angle and a decreased scapholunate angle. So that gives rise to VISI, that is volar intercalated segment instability. That is, volar tilt of the lunate gives rise to VISI deformity. So to remember volar tilt of lunate, it is the lunate axis that we are looking at to decide whether it's a DISI or a VISI, wherein the scapholunate angle reduces and the capitolunate angle increases. So we need to understand the ligament injuries and the sequelae that occurs, like the scapholunate ligament tear causing and later on dissociation and later on secondary osteoarthritic changes. Also, it is important to look at the alignment of the scapholunate and the capitolunate angle. When distorted, that is the simplest way to easily identify changes of DC or VC. Coming to TFCC. Now, before we start with TFCC, we need to know what is ulnar variance. So neutral is the radial styloid and the ulna at the same level. Positive ulnar variance is when the distal ulna, it projects beyond the level of the articular surface of radius. That is known as the positive ulnar variance. And when it is below the level of the distal radius, articular surface, that is known as the negative ulnar variance. Now, TFCC, it is the primary stabilizer of the distal radio-ulnar joint. It cushions the ulnar head and the lunate during the axial loading of the wrist. Now it has multiple components. We'll see each one of them. It is attached to the radial styloid, to the lunate, triquetrum, the fovea, and the ulnar styloid process. So we'll see the components of the TFCC one by one. So firstly, there is this biconcave TFCC disc proper, which is a low signal intensity structure on all sequences. It has a broad ulnar part, a narrow intermediate part, and then an attachment at the radial styloid. Now, at the ulnar part of the disc, there are two attachments. One, it attaches to the ulnar styloid process, and the another that attaches to the fovea. In between that, there is some loose connective tissue which shows a little brighter signal and should not be mistaken for tear. Also, because of the curvature of the foveal attachment, it may have a little intermediate to hyper signal. So it is important to look at the continuity of these fibers. Also, it is possible that because of the position of the wrist, it is possible that you may not be able to identify the ulnar styloid and foveal attachment in one particular image. And therefore, you have to scroll through the subsequent images to see that from the level of the disc, it goes and attaches to the ulnar styloid and then into the fovea, both the attachments. So that's the foveal attachment and ulnar styloid attachment, and the loose connective tissue in between. Also, at the ulno-dorsal aspect, the condensation of the connective tissue at the periphery results in a triangular structure that is known as the ulnar meniscal homologue, okay, which is between the ulna and the triquetrum bone. And small amount of fluid in the prestyloid recess is considered as normal. Now, there are two ligaments, the dorsal and the volar radioulnar ligaments. So if you look at the TFCC in the axial plane, it is a triangular structure. And then this is the articular disc, and it has peripheral attachments in the fovea and the styloid process. And then on either side, at the volar as well as the dorsal aspect, it is reinforced by two ligaments, that is the radius and the ulna. So it's a volar radioulnar ligament and the dorsal radioulnar ligament. So if you look on the sagittal images, if you take section sagittally and you look at this, then that is the dorsal radioulnar ligament and that is volar radioulnar ligament. On the axial also, you can identify this is the dorsal radioulnar and the volar radioulnar ligament. Now, at the volar aspect, besides that, there are two small ligaments that is known as the ulno-lunate and the ulno-triquetral ligaments. They are at the volar aspect. If you see the orientation, how they are attached, they connect the ulna with the lunate and ulna with the triquetral bone. Okay. So that structure on the volar aspect is the ulno-lunate ligament and this is the ulno-triquetral ligament. Now, besides this, some of the TFCC fibers are also reinforced by the ECU tendon sheath. So that sheath of the ECU in the ulnar notch also gets its contribution from the TFCC fibers. So it is important that whenever you see a TFCC injury, you have to look at the status of the ECU tendon. Now, the common pitfalls are what we have seen before: presence of loose vascularized connective tissue between the two peripheral attachments, the ulnar styloid and the foveal attachment, which can be mistaken for a tear. Another thing is that the cartilage overlying the distal radius, it goes at the level of the distal radioulnar joint as well. So this is the black structure is the articular disc, and you should not be mistaking this cartilage as a tear. Thirdly, there is some amount of fluid in the pre-styloid recess is considered normal and should not be mistaken for tear. So these are small structures, but once you understand the anatomy, then scrolling through your sagittal and coronal images will help you identify all these structures. So it's all about the anatomy. You get it right, you'll pick up things which are not seen or which are torn. So let's again scroll through the coronal images from the dorsal aspect to the volar aspect. This is an axial section reference on where we are moving. So first, when we start from the dorsal aspect, at that level, we see the dorsal radioulnar ligament. Then that part is the ECU that we see. Now we start seeing the disc proper as a biconcave structure, okay, having its radial attachment, central portion, and the ulnar portion. You can identify the ulnar foveal attachment and a part of the ulnar styloid attachment. On the next section, you can better identify the foveal and the ulnar styloid attachment. Right? Then we can see the fluid in the pre-styloid recess. That is the ulnar meniscal homologue. That triangular structure is the lunotriquetral ligament. That's the lunotriquetral ligament. Still, we can see the styloid attachment. Now, here we see the ulnotriquetral and the ulno-lunate ligaments. And lastly, the volar radioulnar ligament. Now, if we've already seen the coronal images. Now let's try identifying these structures on the sagittal image. So starting from the level of the radial styloid, you can see that these are the volar radioulnar and the dorsal radioulnar ligament. You start moving medially. You can identify the volar and the dorsal radioulnar ligament, and you now start seeing the part of the disc proper. That is the disc proper. Now tapering towards its apex, okay, and then now you can see a part of the ulnar styloid process, and that's how it attaches at this styloid attachment, whereas that was the foveal attachment, okay. Foveal attachment. And now the styloid process and ECU. So once you've got your anatomy right, let's have a look at the TFCC tears. Now, TFCC tears are a common cause of ulnar-sided wrist pain, particularly during supination and pronation movement. Palmer classification, it highlights the differences in the etiologies of these two types of tears, that is the class 1 is traumatic and class 2 are degenerative. So the class 1 traumatic usually have an history of acute onset. There is a history of fall on an outstretched hand, or there may be an abrupt load to the pronated and or ulnarly deviated wrist. Whereas degenerative has a history of an insidious and chronic onset of pain, and there may not be any precipitating traumatic event. So first, different the traumatic type 1 are have the following types. We'll see each one of them, and later on we'll see the degenerative ones. So starting with the traumatic Palmer 1A, that is the central perforation. Now the thinnest portion of the disc proper, when it gets perforated, when there is a partial or a full thickness tear in this so-called avascular zone, that is known as 1A or central perforation. If it's a traumatic tear, this since it's in the avascular zone, they do not heal, and it may require debridement of the loose flaps. Now, how do you differentiate a traumatic central perforation versus incidentally identified lot many times degenerative central perforation or central tears? So when there's a young patient, acute onset, history of trauma, it's more likely to be a traumatic Palmer 1A rather than a 2A. Whereas it's old age, chronic and insidious onset of pain, likely to be degenerative. There may be associated other degenerative findings that may point towards, that is the changes in the adjacent cartilage and the subchondral bone that may point towards a degenerative etiology. So at times it is difficult to differentiate between a degenerative and traumatic tears, and both of these types of tears may frequently coexist. So the features that favor degenerative tears are there is generalized thinning of the TFCC, or there may be an ulnar positive variant. So when there is an ulnar positive variance, it tends to impinge onto the TFCC and thus making it more likely to have degenerative changes. And when there is a site of tear which is closer to the radial attachment, that also favors a degenerative tear. Now we are skipping the B and the C, looking at the Ds. 1D, Palmer 1D is the radial avulsion, wherein there is avulsion tear at the radial attachment of the TFCC, or it may be associated with an avulsion fracture of the radial rim. And it is important that no amount of tissue should be present at this site. If the tissue is present, then it's more likely to be a central perforation rather than saying it as a radial avulsion. It is important to differentiate this because the treatment is different. Many times the 1A are left alone, or they may, the debridement of the loose flaps, very uncommonly it's done. Whereas the radial tears, they require a suture anchor that fixes this TFCC to the distal radius. And especially when there is an avulsion fracture at this site, then that requires a internal fixation. Coming to 1B, 1B are basically avulsions of the peripheral attachments. It can be either the styloid or the foveal attachment, or there can be an avulsion fracture at the base of the styloid process. And the management depends upon the stability of the distal radioulnar joint. So if the distal radioulnar joint is stable, then only conservative treatment is done, or ligamentous repair, capsulo-ligamentous repair is done to stabilize the DRUJ if it's not stable, and suture anchors are put to fix the foveal tears. So that is how they put the suture anchors and pull the foveal attachment and fix it to the base. So let's see one of the example. So if you can see, that is the disc proper, the ulnar styloid attachment. Let's play again. Keep an eye on the foveal attachment. So that was a foveal attachment tear with an intact ulnar styloid attachment. I'll play once more. And this is the suture anchor fixation for this patient. Since the foveal tears are the most important and they are associated with DRUJ instability. Another case wherein there is 18-month-old with 18 years old male with history of jerk to the wrist and wrist pain. Here you can see that there is a fluid signal at the ulnar styloid process. This is a partial tear with preserved few of the fibers. This is the sagittal image showing the same. So here Since the distal radioulnar joint was stable, isolated styloid attachment tears can be left alone and can be treated conservatively. One more example where you can identify the ulnar styloid fracture at the base. Since the fovea it inserts at the level of base, these are very likely to be associated with foveal tears. Whereas since it's an avulsion fracture, think like ACL fractures, ACL avulsion fractures. When there is an avulsive force which is ripping up the bone from the native bone, then the ligament is not going to be injured. So, like in when there is an avulsion fracture at the styloid base, the styloid attachment is usually going to be intact. Whereas the foveal attachment being inserted in that region is more likely to be injured. And here you can see there is associated marrow edema and the foveal tear. Coming to Palmer 1C, these usually isolated tears of ulno-lunate and the ulnotriquetral ligaments, they don't occur. And they usually occur as a part of other ligamentous injuries. When isolated tears occur, they are classified as Palmer 1C. Now coming to the degenerative type or the type 2 of Palmer classification. So these are a continuum of findings, which we'll see in the subsequent slides. Now, when there is a positive, it's important to state this because the degenerative Palmer classification is the same as the ulno-carpal abutment changes sequentially how they appear. The prerequisite usually is there is an associated positive ulnar variance, and so there is an inherent thinning of the articular disc, and with the increased axial loading at the ulnocarpal joint, gradually it is the TFCC that shows degenerative changes and then the adjacent bones. So how it occurs is first is that there is initially there is just degenerative wear. There is thinning and increased signal in the central portion of the disc proper. Later on, there is complex, along with that, there may be associated changes in the lunate. The lunate cartilage is involved and the subchondral bone is involved. Then there may be perforation and associated ulnar chondromalacic changes, as in this case. Here you can see that there is chondromalacic changes in the distal ulna as well. Then in the next 2D, there are lunotriquetral ligament tear that occurs. And in 2E, besides the lunotriquetral ligament tear, there are changes of ulnocarpal osteoarthritis. As you can see at the triquetrum, lunate, distal radius, as well as the ulna. So it's a continuum of findings that occur from 2A to 2E, 2E being secondary osteoarthritic changes. Now, since the central 80 to 85% of the TFCC is avascular, it has no potential for healing and it may require debridement. When severe young patient, depending upon the clinical scenario, surgical correction may be planned with osteotomy, correcting the positive ulnar variance, thus it impinges onto the disc proper a little less. So that is the management for the degenerative TFCC. So the teaching points are to differentiate. One, firstly, know the anatomy, the parts of TFCC. Differentiating between the traumatic and degenerative is largely based on history. Palmer classification, it is traumatic types and the degenerative types. The degenerative is the same continuum of findings that occurs associated with positive ulnar variance and degenerative changes in the TFCC, later on resulting into arthritic changes. And whenever there is a TFCC tear, it is important to look at the ECU. One condition that needs a mention is ulnar impingement syndrome, which is not the same as ulnar abutment syndrome. Here, there is not positive ulnar variance. Instead, there is shortening of the distal ulna, which tends to impinge onto the distal radius at the proximal to the sigmoid notch. And that results, this can be associated with deformities or fractures causing secondary bony remodeling and resulting in this kind of an appearance. And this ulnar shortening, it results in subchondral sclerosis and marrow edema wherever the distal ulna impinges onto radius. And this is known as the ulnar impingement syndrome. Now we have seen this. So with the positive ulnar variance, it is the TFCC tears and ulnar impaction syndrome or the abutment syndrome that is associated. Whereas with negative ulnar variance, it's the Kinbox disease and the ulnar impingement syndrome that is associated. So now let's have a look at the Kinbox disease. So Kinbox disease, you know that it is avascular necrosis of the lunate bone. It begins as just a edema pattern. There is this Littman class staging of Kinbox disease, which is again a continuum of findings that occur progressively. So initially, it is just an edema pattern in the bone marrow. Later on in stage 2, you start seeing sclerosis on T1 weighted images. We'll see each the third, okay, type 3 is when the lunate collapse occurs, and type 4 is when the radiocarpal or the midcarpal osteoarthritic changes occur. So when you see sclerotic changes on the radiograph and there is a suspicion of Kinbox disease, patient comes for an MR. Patient is not coming for a diagnosis of Kinbox disease. It is already seen on radiographs. What the patient is coming for is, if the lunate collapse is not appreciable on the x-rays, you need to comment on the presence of lunate collapse, one. And number two is secondary cartilage changes that occur at the level of the radiocarpal and midcarpal joints. What stage of involvement of the joints is there and where the arthritic changes are stepped in, that you need to comment on MR rather than just commenting upon the Kinbox disease alone or the saying that there is Kinbox disease. So this is stage 1 to 2, where there is a preserved shape of the lunate bone, but there is presence of, initially there is just T2 associated subtle marrow edema. Later on, there is presence of T1 hypointensity suggesting sclerosis. In stage 3, there is lunate collapse and it starts, fragmentation starts. At the site where the axial loading occurs, then the cartilage changes start coming in. So that is the lunate collapse. And when the cartilage changes start coming in, that is stage 4, where the changes are seen at the level of the radiolunate bone, radiolunate joint, and the capitolunate joint. So for Kinbox, it's important to comment on the level of lunate collapse, 1, and 2, to comment on the cartilage, capitolunate and the radiocarpal cartilage. Now coming to bones and joints. So a patient presenting with wrist pain following trauma, and the wrist x-ray was normal. I don't have an x-ray, but I put a representative CT image. Even on the CT image, it was not visualized. On MR, you can see that there is some kind of a marrow edema involving the scaphoid and the lunate bone. And on T1 weighted image, you can identify the fracture involving the scaphoid bone. Whereas lunate, it was a trabecular injury or contusion. So occult fractures, which are not seen on radiographs or maybe even missed on CT, they are seen as linear low signal intensity on T1 weighted images and with surrounding marrow edema on T2 weighted images. Whereas bone contusions or trabecular injuries, you may not see that dark T1 line, but there may be presence of just marrow edema. Like you see this another case where you see a marrow edema involving the hamate bone. You look at the axial images and you can identify the hook of hamate fracture, which was missed on radiographs. That is a CT image showing the hook of hamate fracture. This is one of the fractures like these scaphoid waist occult fractures that may be missed on wrist radiographs. Another case of a traumatic wrist where there is marrow edema in the distal pole of the scaphoid. Now, okay, so that is a marrow contusion, not a fracture. Now, another thing that whenever there are scaphoid fractures, the MR is done to identify whether there is changes of avascular necrosis. So there has been studies which try to evaluate the role of dynamic contrast MR for scaphoid viability. And it was found that the findings were still equivocal, and the final verdict is that you can still rely on plain T1 weighted images, and when there is presence of sclerosis, it helps identify document that there are changes of avascular necrosis in a case of scaphoid non-union. So you can rely on plain T1 weighted images to comment on scaphoid avascular necrosis. This is another CT image of a 44-year-old male with a vehicular accident 3 months ago, and he had persistent pain. You can't you look at the MR image and you can easily identify the trabecular injury or the fracture involving the distal radius known as the Schoffer's fracture. Now, if you retrospectively try to find, yeah, there is a little fracture line there. But MR can easily identify these fractures which may be missed on CT or X-rays. Now, another 21-year-old male with a complaint of pain in right wrist joint since 1 month, and the pain was aggravated on flexion and extension. He had a recent history of starting weightlifting and gymming. So you can see that there is marrow-edematous changes involving the carpal bones. Here it is involving the capitate and the trapezoid bone. What is important to note is that the marrow edema pattern was unusual. It was two adjacent carpal bones that were showing edematous changes. And if you look closely, this is the site of fibrocartilaginous coalition. So this is fibrocartilaginous trapezoid capitate coalition with stress response. This might be there from beginning, but the patient the young fellow, he started gymming and all, increasing the stresses on the site of coalition, and now has presented with pain as a stress response adjacent to the site of coalition. So presence of unusual marrow edema pattern in two contiguous carpal bones should prompt you to look at the level of the joint, whether there is any coalition or not. Now, this is another case wherein these are the sequential coronal images, T1 and PD fat weighted images, and you can see that there is osseous fusion of the two bones, scaphoid lunates. It's lunate and triquetrum bones. This is osseous lunotriquetral coalition. When there is osseous fusion of the two bones, this is usually an incidental finding, and they usually don't present with stress responses. Rather, they are more likely to present with secondary degenerative changes that occur because of the change in the axial loading, the way the forces are transmitted across the wrist joint. So we saw occult fractures, bone marrow edemas that can be identified on T1 weighted images. Scaphoid avascular necrosis, you can rely again on T1 weighted images to identify the sclerosis. And coalitions, when marrow edema pattern is unusual involving two contiguous bones, look closely for any coalitions. Coming to the tendon, so there are the extensor and the flexor tendons. Now the set of extensor tendons, there are 6 compartments at the dorsal aspect of wrist. I'm not going to name all of them. So what abnormalities can occur in the tendon? There can be tendinosis, there can be tear, there can be tenosynovitis. All right. So when there is a fluid signal through and through across the tendon, that is a tear. When there are edematous changes in the tendon with no fluid signal, that is a tendinosis. And when there is edematous changes or fluid signal encasing the tendon along the tendon sheath, that is tenosynovitis. Just like anywhere else. Here, this is an ECU, extensor carpi ulnaris, longitudinal split tear at the level of distal radius. When you see this kind of tear, as I said earlier, it is important to look for TFCC and associated TFCC tears. Since the ECU sheath, it also receives its fibers from the TFCC, so they are likely to tear in conjunction. Another case, here you can identify that there is first compartment tendinosis with associated tenosynovitis. Another patient where this is the fourth compartment, this is the third and the fourth compartment, second and the third compartment that is involved. So this is decurrence tenosynovitis, when tendinosis tenosynovitis is involving the first extensor compartment, and this is intersection syndrome. What is intersection syndrome? This is when the extensor carpi radialis brevis and longus, that is the second compartment tendons, it crosses the APL EBB. That point of friction results in reactionary tenosynovitis changes, and that is known as intersection syndrome. Decurrent tenosynovitis, it occurs at this level, whereas this crossing over, it occurs about some 3-4 centimeters from the joint line. So these changes are more likely to be in the distal forearm. Now, when there is extensive involvement of all extensor tendons, that is extensor tenosynovitis, and with adjacent surrounding synovial inflammatory changes and edematous changes, you start thinking in terms of inflammatory infection. Now, when you see associated inflammatory changes within the joint, associated osseous erosions, this is a case of rheumatoid arthritis. So you have to correlate these findings with other findings in the wrist as well as the history. Now, this is another young female with unilateral wrist pain and swelling since 8 to 9 months. We'll scroll through the axial images. There are changes of tenosynovitis in multiple extensor as well as the flexor compartments involving multiple tendons. There are changes of tenosynovitis also in the distal radioulnar joint and along the wrist joint. You can see that there were erosive changes, synovitis, diffuse soft tissue edematous changes. There were a few dark areas also where the changes of synovitis were there. This is a proven case of TB on synovial biopsy. At times, it is difficult to differentiate infective versus inflammatory, that is chronic infective tuberculosis versus inflammatory changes as in rheumatoid arthritis or non-specific synovial inflammatory changes. And therefore, you have to rely on the clinical findings when it's a female presenting with morning stiffness, multiple joints are involved. It's more likely to be rheumatoid arthritis. Monoarticular joint involvement, chronic insidious onset, it can be tuberculosis, and synovial biopsy needs to be done to differentiate these two. Now, this is another young male with discharge and skin discoloration of palm. So you can see that there are some edematous changes around the flexor tendons. You look at the axial images, these are T2 weighted images, and you can see that there are edematous changes in the subcutaneous plane. There are some dirty looking areas in the subcutaneous plane. There is inflammatory changes encasing the flexor tendons. There are some dark areas along the flexor tendons. These are the sequential axial images. Now the T1 weighted images. Okay, you can appreciate these rounded areas. This is post-contrast images which shows peripheral enhancement surrounding these rounded areas and mild enhancement along the sheath as well as in the adjacent soft tissue edematous changes. So this was a case of proven mycetoma. You can appreciate those rounded structures. Those are known as dot in a circle sign, where the dark foci is the fungus, the surrounding bright is the granulation tissue or the response, and then that may be further encased by a fibrous septa, which is not much appreciated here, but you can appreciate the dark foci and surrounding bright rim. So that is the dot and circle sign for mycetoma or actinomycosis. So teaching points for extensor tenosynovitis. Look at the compartment, it's 1 or whether it's 2, 3. What site is it? Is it at the anatomical stuff box, or is it at the is it at the level of the joint, or is it at the distal forearm? When differentiating, when the tenosynovitis is associated with other synovitis, osseous erosions, think in the lines of infection, inflammatory, associated such circle and dot signs. You think of atypical infections, and in these cases, synovial biopsy is required to confirm the diagnosis. Coming to tendon injuries, a 28-year-old female presented with a history of trauma. Here you can see that there is, this is very well depicted in this single image. At times it's not that easy. There is tendon retraction. This is the wavy torn proximal tendon, and this is the distal torn end. Okay, so this is complete. This was complete tear of the flexor carpi ulnaris with retraction. So whenever you encounter penetrating injuries, or very commonly we have there's a past history of glass injury, and then CLW was taken at the site of the injury, and then the patient was unable to move the thumb. or unable to move a particular finger. Specifically, it's important that you put a tablet marker at the scar site. Secondly, you screen a little above and little below the joint so that you don't miss any tendon injuries and tendons which have retracted. So let's have a look at this axial section. Here you see some kind of an abnormal tendon with edematous changes, tenosynovitis. We can appreciate it here. And at the distal radius, we lose it, and we don't see it. Then there is some another tendon stump in this region as well as in this region. So this was extensor carpi radialis brevis tendon injury. This is the proximal torn end. This is the distal torn end. You need to mention where the proximal end is at the level of the distal carpal row, where the distal torn end is at the level of the base of metacarpals, and what is the extent of tendon retraction. Another tendon that was also torn was the extensor pollicis longus tendon. So that is one end, and this is the distal torn end, and that much from here to here, that was the extent of retraction. So you need to tell that injury was somewhere here, and you need to tell where the proximal and the distal torn ends are. So that's about tendon injuries. Now coming to the flexor compartment. The flexor compartment comprises of the flexor tendons, flexor digitorum superficialis and profundus. There is a median nerve. There is a Guyon's canal, which has ulnar nerves and vessels. And there is a flexor retinaculum, which encases the flexor digitorum tendons and the median nerve. So when do these patients come for MR evaluation for nerve impingements? At the carpal tunnel for median nerve and at Guyon's canal for ulnar nerve. Now, carpal tunnel syndrome, it's a clinical diagnosis, and they don't usually need an MR for the diagnosis of carpal tunnel syndrome. So why do they come for? They come for when there is failed carpal tunnel syndrome. The patient has already been operated, and the findings, the clinical symptoms have not resolved. So they come for evaluation of failed carpal tunnel syndrome. Now let's have a look. This is the section that was taken, that is just proximal to the carpal tunnel. So you can see the thickened, enlarged median nerve with the fascicle seen. This is the part of the flexor retinaculum, right? And you can see that there are edematous changes in the flexor compartment around the flexor tendons, which may be responsible, contributing to the carpal tunnel syndrome or median nerve compression. Now, when there is cases of failed carpal tunnel surgery, it may be due to a space occupying lesion, which is contributing to the pressure in the flexor compartment and causing median nerve compression. So there may be a cyst which is compressing on the flexor compartment. There may be a schwannoma, or there may be a hematoma. My animations have gone wrong. Okay. So another thing that can occur is, this is another case, a female who presented with post-release persistence of symptoms. And you can see as we scroll through from the proximal level of the radius, you can identify the flexor tenosynovitis. Let's just go a little back, right? So you can identify the median nerve here. That is the flexor retinaculum. The changes of flexor tenosynovitis. That is the median nerve. Now we move forward. At the level of the retinaculum, which is, this is the flexor retinaculum, the median nerve is markedly compressed. It's markedly compressed. And where the flexor retinaculum finishes, at that level, now you can identify the median nerve further dividing into its branches. But the presence of flexor tenosynovitis is the contributing factor for persistence of complaints. Another case where there was carpal tunnel release was done. Here you can see it's important again to put your tablet markers at the site of surgery so as to identify the problem easily. Here you can see that there is thickened carpal tunnel. There is scarring in the subcutaneous fat and the skin at the level of where the surgery was performed. And also you can appreciate that the median nerve has not been released adequately. It is still compressed, or probably there is scarring that is also contributing to the incomplete release. And you can see that there is persistent median nerve compression at this level. So that was responsible for the failed surgery. Coming to Guyon's canal, in Guyon's canal, you have to identify space-occupying lesions that may be impinging on the nerve and causing ulnar nerve complaints, like a ganglion cyst in this case, in the Guyon's canal, or an ulnar neurogenic tumor, as in this case. So now to recap, we have looked at the ligaments and alignment. Amongst the ligaments, we have looked at the intrinsic ligaments, scapholunate and lunotriquetral ligament. Scapholunate ligament giving rise to scapholunate diastasis, and then DC, and then slack wrist. Lunotriquetral ligament giving rise to VC. TFCC, we've seen the traumatic and the degenerative type of the Palmer classification, and its importance highlighting the changes in management that occur with different types of tear. Ulnocarpal abutment, which is degenerative TFCC tear or Palmer 2 classification, where the continuum of findings occur associated with positive ulnar variants, degenerative wear of the TFCC, and then secondary osteoarthritic changes in the bones, surrounding bones. Kinbox disease, where it's not identifying and diagnosing Kinbox that is important, but to mention about the lunate collapse and the involvement of the cartilage at the capitolunate and the ulnolunate joint, which is important. Occult fractures and contusions, which may be picked on MR and may be missed on X-rays. Coalitions, when two subjacent bones having abnormal marrow edema in close proximity, look for coalitions. When presence of synovitis, think of rheumatoid and chronic infective etiologies. Synovial biopsy helps, history helps pinpoint the diagnosis, serological markers help. Septic arthritis, one way to differentiate septic arthritis is taking an additional diffusion weighted images. When there is pyogenic septic arthritis, diffusion weighted images can help identify diffusion restriction within the fluid component, suggesting that it is possibly pus. And then you can already see the associated marrow edema and erosions suggesting joint involvement. So septic arthritis can be differentiated from the chronic infective and inflammatory etiologies by diffusion weighted images. Tendons, depending upon what compartments are involved, you can pinpoint what is the diagnosis, whether it's Duchenne veins or intersection syndrome. Carpal tunnels and impingements, here it is to identify the cause of failed surgery usually, and to identify whether there are any space occupying lesions contributing to the carpal tunnel syndrome. So it's important that we have a systematic approach to evaluation of the wrist joint, and a checklist approach helps to identify all the findings. At the same time, I would like to stress that putting tablet markers are very important, because there might be multiple non-specific findings, and the tablet marker can help narrow it down to the site which is causing the complaints. Right? So if you want, we can take a little break here and take a few questions, or we can move on to carpal instability.
We'll just ask if there are any more questions then.
Yeah.
So are there any more questions? Any questions?
No, sir.
Ma'am, I guess we'll continue and then we'll...
All right. So if
you
have...
I have sent the question to Saitali Parikh, ma'am.
Okay, she'll ask then. Fine.
So ask.
If you can put Chaitali is there, I guess she'll. If you have the questions right now, you can share.
I'll share in Zoom.
Yeah, chat box. Yes, yes.
Yeah, sir. Yeah, okay. Sir.
You can share the questions on chat box, then we'll ask.
All right. So should we wait or should we move ahead?
Ma'am, just a moment. I'll see how many questions. If there are
Ma'am.
only few.
Ma'am, I'm sharing, ma'am.
Okay. Yes, ma'am. Ma'am, we have four or five questions. Would you like to take them now or?
Yeah, we'll take it right now so that it breaks a little monotony also, and then we'll start with carpal instability.
Yeah. So, ma'am, the first question is: central perforation is in middle of disc or towards radial side of TFCC, I guess.
It is in the, yes, it's in the narrowest portion of the disc. So it's a biconcave appearance. So where the disc tapers, that portion is the central portion where the central perforations occur.
Yes, ma'am. The second question is Palmer 1A and 2A, same region involved. I guess, okay. So they want to know whether the same region is involved or
So,
are they?
yes. In Palmer 1A and 2A, it is the same central portion that is involved. Only that that is more about probability. The degenerative ones, that is the 2A, are more likely to be towards a little over the radial side. Then proper intermediate zone, that is one. Secondly, rather than relying on the appearance, it is important that you identify the surrounding appearance, whether there is presence of positive ulnar variants, whether there are changes in the adjacent cartilage, adjacent bones are showing any subchondral marrow edema, the patient is having a chronic insidious pain history, there is no traumatic event, then it's more likely to be degenerative. Whereas the young patient having an acute onset of complaints, fresh looking clean tear in the center, then it's more likely to be a traumatic and a 1A.
Surya, your mic is off.
Hello, ma'am,
Yes.
am I audible?
Yes,
Yeah.
now you're audible.
Okay, how to differentiate between SNAC and SLAC radiologically? So,
okay, so SLAC is basically scapholunate advanced collapse that occurs as a continuum of ligamentous injury. So scapholunate ligament injury occurs. Eventually, the complete scapholunate ligament tear occurs. Associated extrinsic ligament tear occurs. That's why a scapholunate dissociation happens, where there is increase in the interval between the scapholunate bones. Increased scapholunate distance is there. That is the Terry Thomas sign. Later on, the lunate tends to tilt dorsally in relation to the scaphoid, and there is a volar tilt of the scaphoid. So the scapholunate alignment alters, resulting in a DC. Since with the DC, the axial loading forces, it acts differently on the way the forces are transmitted through the wrist joint. So that results in progressive cartilage changes and osteoarthritic changes, which begin at the level of the distal radius and the scapholunate ligament, then the entire radioscaphoid articulation being affected, capitolunate, midcarpal, and later on the distal radioulnar joint being involved. So multiple arthritic changes. So when these arthritic changes that set in, that is a SLAC wrist, which occurred as a result of a ligamentous injury. Whereas SNAC wrist is scaphoid non-union advanced collapse, where the primary event is a scaphoid fracture which did not unite. There was non-union. The non-united fracture fragment tilted in a particular position, or it was contributing to secondary arthritic changes henceforth, and that's why it has occurred. So that is a SNAC wrist. So the initiating event is different. End result is probably the same with changes of arthritis.
yeah, and ma'am, last question is how to differentiate between scaphoid fracture marrow edema from early AVN?
So fracture marrow edema occurs at the site of the fracture, which is more commonly the waist. AVN occurs in the proximal pole. So when your edema is centered around the fracture line, it's more likely to be associated with the fracture and in the acute setting. Whereas when it is the edematous changes are predominantly in the proximal pole, and you start seeing T1 hypointensity suggesting that changes of sclerosis, then that is AVN.
Yes, ma'am. Thank you so much, ma'am. And after this, we'll take the other questions together then, I guess.
All right.
Okay.
So let's minimize this and start. So carpal instability, now that's a very complex topic. Again, it's important to know the anatomy. Since we are going to talk about the MR, obviously the first investigation for identifying carpal instability are the radiographs. and you probably an entire lecture has been taken on the wrist radiographs. So very basic important thing when you look at wrist radiograph is that these Gilula carpal arcs should be parallel and well maintained. These arcs are along the proximal and the distal carpal row on the PA view, right? And on the lateral view, at least you should be able to identify the distal radius, the lunate, and the capitate bones. This is the scaphoid, right? So this radius, lunate, and capitate in alignment. Okay. So besides the alignment that can be seen on radiograph, MR adds additional information related to the bones, cartilage, and the ligaments, and that's why it's important. Before we start, you need to know the arcs. We already seen this. The carpal arcs along the proximal and the distal carpal row. You need to know the axis. We have already seen it, but I'll just elaborate on them. Scaphoid axis, that is the line which joins the mid portion of the proximal and the distal poles of scaphoid, is the scaphoid axis. Lunate axis is the one which is a line which is drawn perpendicular to the line joining the distal palmar and dorsal borders. So that is the lunate axis. The capitate axis is the one which is joining the mid portion of the third metacarpal to the proximal surface of the capitate. So the lunate and the scaphoid axis, the angle they make is the scapholunate angle, which normal is 30 to 60 degrees. The capitate and the lunate axis, the angle they make is the capitolunate angle, which is normal less than 30 degrees. Another one more angle, which is important to establish that the radius and the carpal bones are in alignment, is the radiolunate angle. That is the which goes along the long axis of the distal radius and the lunate axis. That is the radiolunate angle should be less than 15 degrees. We have briefly seen DC and VC resulting from the ligamentous injuries. So let's just do a recap. All right. So when there's a dorsal tilt of the lunate, that is DC. We have seen ligamentous DC, scapholunate dissociation due to ligamentous injury resulting into DC. It can occur because of wrist trauma with or without a fracture. So when there is a scaphoid fracture, there is a fracture fragment, it changes its alignment. And because of the change in the alignment of the scaphoid axis, as a result of this, there's change in the scapholunate angle, and that is a bony DC. When there is a distal radius fracture, say there is a fracture in the distal radius, and there is a dorsal, there is an angulation of the distal radius. With it, the lunate also tends to change its alignment, and that is how the scaphoid and the lunate relationship changes. The angle between the scaphoid and the lunate changes, and that DC is the compensatory DC. When there is the fracture, it unites in a malunited position. So radius malunion occurs, and it angulates dorsally. Along with it, the lunate is also in a dorsally angulated position. That is adductive DC. All right. So the when there is a dorsal tilt of the lunate, change in the scapholunate and capitolunate angle when they increase, that is known as DC. It can occur due to ligamentous causes. It can occur due to bony causes. Whereas VC is when there is a volar tilt of the lunate axis, where the scapholunate angle reduces less than 30 degrees and the capitolunate angle increases. This usually occurs due to disruption of the lunotriquetral ligaments. So this is an MR image showing the dorsally tilted lunate axis, that is DC, and this is the volarly tilted lunate axis, that is VC deformity. Okay. Now we had skipped the extrinsic ligaments previously. On routine MR, usually unless there is a carpal instability, we do not look for the extrinsic ligaments. But it is easy, and once you know the anatomy, you will be able to identify these structures, or rather you start seeing them and noticing these structures on your normal MRs and their orientation, and you will be able to pick up when they are injured. So extrinsic ligaments are the ligaments which originate in the forearm, that is they attach the radius or the ulna with the carpal bones, unlike the intrinsic ones which connect in between the carpal bones. So there are set of ligaments, lot of ligaments on the dorsal aspect. Only two are important. That is, at least for us, is, and they can be easily identified on MR, is the dorsal intercarpal ligament and dorsal radiocarpal ligament. On the volar aspect, there are multiple ligaments, and we'll see one after the other. Of this, there are 2 to 3 ligaments which are important. So first, let's start with the dorsal part. So on the dorsal part, if you see, there is a dorsal radiocarpal ligament which connects the distal radius with the triquetrum, and the dorsal intercarpal ligament, which is basically from the triquetrum to the scaphoid, crosses over the carpal bones and attaches to the scaphoid. Besides that, it has further smaller attachments to the adjacent smaller bones as well. But for us, from triquetrum to the scaphoid is enough to identify this major structure. Okay, so looking at these consecutive sagittal images, I am starting from the level of the radius. This you can identify that there is scaphoid. I'll move back and forth to help you identify. So from here, we can see that there is some kind of a structure here at the level of the scaphoid. Keep your eye on that. It crosses over the carpal bones, and inserts onto the triquetrum. So that is the dorsal intercarpal ligament. Let me move back. That is the dorsal intercarpal ligament. Now, keep your eye on this structure, which is starting from the radius and coursing and meeting at almost the same point at the triquetrum. That is the dorsal radiocarpal ligament, or the radiotriquetral ligament, right? So that is the dorsal radiocarpal ligament, and that is the dorsal intercarpal ligament. All right. Now, looking at these on the coronal images. So there are only a few sections because these ligaments are in plane. You can identify them, or you can grossly identify that is the region where injury has occurred whenever there are edematous changes or traumatic changes in this area. So on coronal images, you can see them in plane. Here, you can see this structure which is going from the distal radius towards the triquetrum. So that was dorsal radiocarpal ligament. And there is another structure which is crossing over all the carpal bones from the triquetrum towards the scaphoid. Let me just move back. So that is the dorsal intercarpal ligament. Right? Now coming to the volar aspect. On the volar aspect, there are a lot of ligaments. You remove this, the TFCC part, we have seen that. Let's divide on one side what is important at the level of the radioscaphoid. There are long radiolunate and the short radiolunate ligaments. Basically, if you can identify a structure which connects the radius with the lunate, that are the radiolunate ligaments. Okay, and another one which begins from the radial styloid, crosses over the scaphoid and inserts onto the capitate. That is the radioscaphocapitate ligament. These are the two ligaments which are of importance on the volar aspect. Whereas on the ulnar aspect, there is from the capitate to the triquetrum, and then it goes forward. There are small parts of the ulnolunate and triquetral that are also there. So it blends there. So from the triquetrum, hematocapitate, that is the THC ligament. Okay. So it's triquetro-hemato, crosses over the hemat, inserts onto the capitate. Triquetro-hematocapitate ligament. Okay. Which is important. Yes. Sorry, I was triquetro-hematocapitate ligament. So now looking on the volar aspect, you can identify from the level of the distal radius, there is this structure which from the radius onto the lunate. So that is the long radiolunate ligament. Okay. Another one structure which is radioscapho, this structure which is crossing over the scaphoid and inserting onto the capitate is the radioscaphocapitate ligament. Now beginning from this forward, capitate and moving forward and inserting onto the triquetrum is the triquetrocapitohemate. Okay, but most of the times consistently you will be able to identify the radiolunate, long radiolunate and the radioscaphocapitate ligaments on the volar aspect. These are the coronal images again in plane, where you can, depending upon the direction in which it is going, you can identify that this was the one which was connecting the capitate with the triquetrum across the hamate. So triquetrohematocapitate ligament, whereas this was let me move a little back and forth. So from the radius, from the level of the radius, sorry, and towards the capitate across the scaphoid, radioscaphocapitate, okay, ligament. And another one here, which is the radiolunate ligament. Okay, so only three important, of which two most important, radiolunate and the radioscaphocapitate ligaments. Now, one thing worthy of note is that there is, at the volar aspect of the wrist, see how the extrinsic ligaments are arranged and connecting the forearm bones with the carpal and carpal bones, right? So there is a space, triangular space between the capitate and the lunate, which is not reinforced by any of the ligament, and that space is known as the space of Poirier. This is the potential space or potential space of weakness, that when these ligaments rupture, the instability occurs in this region. So it is this space that widens and results into perilunate instability and lunate dislocations. Coming to carpal instability classification, a carpal instability can be divided into following types. We'll see each one by one. First is carpal instability dissociative, CID, wherein there is derangement within or between the carpal bones. So first we start with instability or derangements in between the carpal bones, like the scapholunate, lunotriquetral. These all fall in the carpal instability dissociative. When there is derangement in between rows, that is between distal radius and proximal carpal row, or between proximal carpal and distal carpal row, with the intercarpal alignment remaining normal, that is known as carpal instability non-dissociative. And carpal instability complex is when there is derangement occurring in between the carpal bones as well as in between the rows, as in distal radius, proximal carpal, or proximal carpal, distal carpal, as well as intercarpal derangements. So that is the carpal instability complex. And carpal instability adductive is where the cause is either proximal or distal to the carpal bones. For example, like there is a old radius fracture, malunion, causing bony remodeling and misalignment, and as a result, the carpal bones are misaligned. Or say Madelung's deformity and resulting into carpal misalignment. So that is carpal instability adductive. So what we are going to look at is, we have already actually seen the carpal instability dissociative. The most important of this is the derangements occurring in between the proximal carpal row, that is scapholunate dissociation and lunotriquetral dissociation. We have had repetitions of this already. So scapholunate ligament tear, eventually dissociation, DC, resulting in eventually slack wrist. So this is carpal instability dissociative, CID, resulting from scapholunate ligament tear. When the DC deformity, it occurs because of the scaphoid, say all non-united fracture or scaphoid. So here you can see that there is non-united fracture of the distal pole of scaphoid. If you look at the sagittal plane, you can see that how messed up the alignment, how messed up the axis of the scaphoid is. This is probably the axis of the scaphoid. And you can see that the lunate is also a bit dorsally tilted. And so this is DC deformity resulting because of the scaphoid fracture and non-union. This is an example of a bony DC. Another example is when there is lunotriquetral ligament tear and resulting into a VISI deformity. So whenever misalignments, they occur in between the carpal bones, because of the intrinsic ligament tear, like a lunotriquetral or scapholunate ligament tear, that is carpal instability dissociative. Coming to non-dissociative, meaning there is problem or derangement between the radius and first carpal row, wherein it's known as radiocarpal instability, or it is between first and the second carpal row, where it is known as the mid-carpal instability. Now, when there is derangement in between rows, the alignment in between the carpal bones amongst the same row remains maintained. And therefore, when it is the distal radius and proximal carpal row misalignment, or proximal carpal and distal carpal row misalignment, then it is the extrinsic ligaments which are injured. So radiocarpal instability can be of various types. It can be an ulnar dislocation, radial dislocation. There are multiple types, but we are going to look at only the ulnar translocation. Okay. So ulnar translocation is that there is tearing of the extrinsic ligaments of the wrist, and that is resulting in the ulnar shift of the proximal carpal row in relation to the distal radius. Okay, so the entire proximal carpal row moves ulnarly and in relation to distal radius, that is ulnar translocation. They are of two types. Type 1, it would be easier for you if you just remember the images. That is, here you see that there is some derangement at the level of radius and the carpal bones. So this is basically what it is: carpal instability, non-dissociative. Right? Now, what is the abnormality? Here, there is widening of the radiocarpal space, or radioscaphoid space, or radiocarpal space. So when the radioscaphocapitate or the radiolunate, long radiolunate ligaments, they get torn, there will be widening of this space that will result in this entire carpus moving towards the ulna. And this is known as ulnar translocation type 1. Here you can note that the scapholunate interval is maintained. There is no ligamentous injury at this level. Versus ulnar translocation type 2, wherein the injury occurs at the level of scapholunate ligament 1 and along the long radiolunate ligament, that is the extrinsic ligament. So this results in only the lunate, triquetrum and the pisiform bones being moved towards the ulnar direction and away from the distal radius. Okay, whereas the radioscaphocapitate and radioscaphoid, that is the radioscaphoid interval, is preserved in ulnar translocation type 2. This is, you can say, a very severe form of scapholunate dissociation, where the ligament and the extrinsic ligament, long radiolunate ligament, that is injured and resulting into an ulnar translocation type 2. Now, where the third carpal instability type, that is carpal instability complex. This is probably the most important. Probably this is the one which you are asked in exams about. When here the injury, it is not in between the carpal, it's between the carpal bones of the same row, as well as the derangements in between the rows, that is distal radius versus proximal carpal, or proximal carpal versus distal carpal row. So there are multiple types. We are going to see only the first two, because the perilunate, because of the presence of space of Poirier at the volar aspect, it is the dorsal dislocations of the lunate that occur. And dorsal perilunate dislocation are quite common. There are 4 types in it. And when these perilunate dislocations are associated with a fracture, then they are known as dorsal perilunate fracture dislocations. Okay, palmar dislocations are very rare. We are not going to look at the other types. So coming to perilunate instability. So there are 4 stages that go through. It is before you understand this perilunate instability, it's important to understand how the forces are transmitted across the joint so as to result in this kind of injury. So when there is a hyperextension force at the dorsal, hyperextension force at the wrist joint, like a fall on an outstretched hand. So the forces, they get transmitted from across the radioscaphoid and towards the scapholunate joint. So the first thing that happens is the scapholunate disruption. Okay. Later on, these forces are transferred across the capitolunate joint. So there is capitolunate disruptions occur. Then it is the lunotriquetral joint that is disrupted in the third perilunate instability. And now if you see that if the forces have passed through this region, disrupting the ligaments all around the lunate is going to be unstable, right? And when lastly, there is the short radio lunate ligament and the radiocarpal ligaments get disrupted, then the lunate gets dislocated outside. So that is how lunate dislocation occurs. There is an alternate osseous pathway for transformation of forces where it's not through the ligaments but through the bones, meaning there occurs fractures. So there can be a transradial styloid fracture, transscaphoid fracture, okay? Then there can be a transcapitate fracture in stage 2. Then there is a transtriquetral fracture. And lastly, it is at the volar aspect, the ulnotriquetral ligament and the long radiolunate ligament that are injured. Forces may be transmitted across the ulnar styloid process and eventually resulting into an ulnar styloid fracture. So it helps to understand how the sequential changes occur. So there might be a lot of write-up, but you focus on what I'm saying. So first, stage 1, the forces were being transmitted through the scapholunate joint. So the first perilunate instability is the scapholunate dissociation, where there is an hyperextension force to the distal carpal row. Now the lunate, it cannot extend as much as the scaphoid, okay, because it is held by the extrinsic ligament. So when at a particular point, when the force, it goes beyond that it can take, the scapholunate ligament starts tearing. It tears from the palmar to the dorsal aspect. And eventually when the dorsal component gives away, there is entire ligament being torn and resulting into distraction at the level of the scapholunate joint, resulting in an scapholunate dislocation. So that is stage 1 of perilunate instability. Secondly, now with the persistent force, the scaphoid capitate row complex, it may dislocate dorsal to the lunate as it is being dissociated from the lunate. So this will depend upon the status of the radioscaphocapitate ligament at the volar aspect. Here in stage 2, it is the entire distal row which is dissociated, and also the radial portion of the proximal row which will be dissociated, and it will follow the capitate. The entire distal row will follow the capitate, and this will result in opening of the space of Fourier. So this change in the alignment of the lunate bone, this is perilunate instability. Here it is the capitolunate joint that is getting disrupted. Now, if the hyperextension persists, so you remember that figure, the forces now get transmitted through the lunotriquetral joint, right? So if the extension persists, then the triquetrum is also being pulled into extension. So the force is being taken by the lunotriquetral ligament. So the lunotriquetral ligament gives away, or if the forces are transmitted through the bone, then the triquetral fracture occurs. And once there is complete disruption of the lunotriquetral ligament, then there will be what happens is the mid-carpal instability, or the stage 3. Lastly, when the lunate has lost all its attachments from all the 3 sides, so finally the dorsally displaced capitate, it will move downwards towards the proximal carpal row and throwing the lunate out of the joint. The lunate may remain attached by the short still intact radioscaphocapitate ligament, but when it tilts outward, that is known as the stage 4 of perilunate instability, known as the lunate dislocation. So you understand here that perilunate instability, stage 2 is the perilunate dislocation. Stage 4 of perilunate instability, where the lunate is thrown out of the joint, is lunate dislocation. Okay, where there is rotary displacement of the lunate out of the joint and the capitate, it tends to move downwards towards the proximal carpal row. To remember easily for exams, this is important. That is perilunate dislocation, the radiolunate articulation is maintained. It is the capitate that is moving dorsally and it is taking along with it the entire distal carpal row. Right? As we progress from 3 towards 4, lunate dislocation, the lunate is getting out. So it is the radiolunate articulation that is disrupted in lunate dislocation. So you need to remember radiolunate articulation is disrupted in a lunate dislocation. Okay. So if you have understood all this, these are the stages of the Mayfield classification. That is how you remember that figure, how the forces are transmitted from the scapholunate joint to capitolunate joint to lunotriquetral joint, resulting in the injury at that particular ligament, scapholunate interosseous ligament and the radioscaphocapitate ligament, then the radial collateral ligament, then the lunotriquetral ligament and associated extrinsic ligaments, and lastly, the dorsal radiocarpal ligament. Or when there is an osseous involvement, that is how the fracture lines also pass through. Either it's transscaphoid, transradial, transcapitate in stage 2 and transtriquetral in stage 3. So this is an example. Look at the sagittal images where you can see the scaphoid, the lunate, radiolunate alignment is there, and then there are a lot of other fractures. You can see that there is distraction at the radioscaphoid joint. Scapholunate ligament distance is also increased. Capitolunate ligament joint space is also increased. Associated, there were lunate fracture was there, and there was fracture of the triquetrum bone as well as the ulnar styloid fracture was there. So this is perilunate instability with associated fractures. So this is when perilunate dislocations are associated with fractures, as we have seen an example before, then that is group 2. Just pure ligamentous injuries, that is group 1. Lastly, carpal instability adaptive, where the cause is not at the carpals, but at a level proximal or distal to the carpal bones, like in Madelung or previous trauma fracture malunion resulting in carpal misalignments or derangements. So this is the Madelung deformity and resulting in the abnormal alignment. There is sloping of the distal articular surface of the radius, and therefore there's the resultant V-shaped orientation of the proximal carpal row, and the capitate also being pushed more proximally. So that is carpal instability adaptive. So the take-home message is the anatomy is complex, but remember the basics, remember the alignments. Look at when you see there is some kind of a misalignment, then you measure the scapholunate angle, you measure the capitolunate angle, look at the radiolunate alignment. Next, try to identify where the issue is, either where the derangement is, whether it is intercarpal or is it between the radius and proximal carpal row or proximal and distal carpal row, and then try to identify the continuum of findings that we saw in perilunate instability to identify and differentiate perilunate dislocations versus lunate dislocations. Thank you very much. It was an exhaustive, long lecture. I hope I didn't lose you somewhere in the middle when we were talking about the ligaments. If you have any queries, I will be happy to answer those.
Thank you so much, ma'am, for this really exhaustive session, but a really in-depth knowledge about carpal instability. There are a couple of questions.
Right.
Can you please share the Palmer classification list again?
It's all these things are already there. If you Google it, you're going to find it.
Yeah.
Right. So I'll just briefly say Palmer classifications: traumatic, degenerative. Traumatic, degenerative are think in the way ulnocarpal abutment occurs, and you will be able to remember it, right? And traumatic is 1A is central perforation, 1B is the peripheral attachments being torn, so it's the styloid or the foveal attachment being torn. C is rare, where there are volar small ligaments, ulnotriquetral, ulnolunate, isolated tears, which hardly never happens without other ligamentous injuries. And 4 was the radial side avulsion of the disc.
Okay. Second question is, can you please explain the concept of BC and DC again?
Okay. That we can do because my screen is shared
No.
yet. No. Okay.
Yeah, now we can see this. Again, we lost the screen. Yes, it's visible.
So easiest way is to identify the first eyeballing, looking at whether your radius, distal radius, lunate, and capitate are in alignment or not, and the angle of the scaphoid. Then you measure, if you see it seems to be abnormal, then you measure the scapholunate and the capitolunate angles. DC and VC are defined by the lunate axis. So when there is a dorsal tilt of the lunate axis, when there is a dorsal tilt of the lunate axis, this is the lunate bone, this is the lunate axis, this is dorsal, this is volar. So when the lunate axis, it tilts dorsally, that is, and resulting in an increase in the scapholunate angle, that is DC. Versus VC, wherein there is, this is the lunate axis. So when there is volar tilt of the lunate axis, that is resulting in a reduced, obviously, scapholunate angle, increased capitolunate angle, that is VC.
Okay. Next question is, can you explain once again about AVN of scaphoid?
Okay. So AVN of scaphoid, it can be seen as early as a week of the fracture. When there is a fracture, usually it's at the waist. Wherever the fracture line passes, that is where the edema is going to be centered surrounding the fracture line. When the vascular supply to the scaphoid is disrupted, it is the proximal pole that undergoes avascular necrosis. Initial finding is appearance of marrow edema in the proximal pole. So the edematous changes will be covering the entire proximal pole rather than towards the fracture line, which is at the waist. When the sclerotic changes that are seen on T1 weighted images set in, you can say on MR that there is avascular necrosis of the proximal pole of scaphoid associated with fracture of scaphoid.
Okay. I think that's it. Any more questions, Team Vidotto? Team Vidotto, any more questions?
No, ma'am. That's it as of now, ma'am.
Okay. So thank you so much, Rishi ma'am, for this wonderful session.